it's me again, it's Val, and we're back with another summary. Today we're going to be doing pulmonary embolism, which I think corresponds to week 11 in our syllabus. And I did all of this last night. I'm very proud of myself. I did it in 3 hours while Joey was playing RuneScape, which is great. And yeah, so just gonna get a little bit into it. So pulmonary embolism, as the name implies, replies to the presence of an embolus, or kind of a piece of tissue or a clot or something that's obstructing the pulmonary or lung circulation. So let's start from the beginning, looking at risk factors. So the risk factors for a pulmonary embolism, and today we're mainly talking about thromboses, so blood clots. The risk factors can be summarized using Virchow's triad. So Virchow's triad points to the 3 things that predispose someone towards developing a clot. So these 3 things are vessel wall damage, hypercoagulability, and venous stasis. So under these headings, we've got the risk factors that make someone more likely to have a pulmonary embolus. Things that contribute to vessel wall damage include age, trauma in the past few weeks. So say if you'd broken a bone and your vessels had been ruptured, that healing process, as well as the damage to the vessel wall, predisposes you towards emboli. In addition, obesity and smoking contribute to vessel wall damage as well. Obesity due to the higher levels of LDLs and cholesterol, and smoking due to the general inflammation that it causes, as well as the immunosuppression. Things that contribute to venous stasis can include having surgery in the past 4 weeks and being immobile for more than 3 days. Hypercoagulability can be contributed to from malignancy, so that is if you have cancer, your blood is more coagulable. If you're pregnant or on the pill, because estrogen contributes to coagulability. If you have a coagulopathy, so if you have a genetic mutation in one of your antithrombin proteins, or if you have an excess of your thrombotic proteins. And if you've had a previous history of venous thromboembolisms. So if you have a bunch of these things, you're going to be more predisposed towards deep vein thromboses. So a deep vein thrombosis is basically where you might have a clot that forms in the deep veins of your lower limbs. And the reason it's in your lower limbs as opposed to other limbs in your body is because you get venous pooling when you're standing or when you haven't moved around for a while. And so your blood isn't moving as well as it could be, and so it's more likely to clot. And this is more likely in people with varicose veins, which is where you have an insufficiency of your valves. So once you have a deep vein thrombosis, what's going to happen is that it's going to travel up through the IVC, the inferior vena cava, and then we'll transfer to here, into the right atrium, the right ventricle, and into the pulmonary circulation. And so you can see here that this clot has traveled into the pulmonary vessels and has caused hemodynamic compromise. So what happens here is that once a vessel has been occluded in the pulmonary circulation, the tissues that lie distal to that embolus are not going to be receiving any blood. And so you get what's called a VQ mismatch, or a ventilation perfusion mismatch. So in this case, we're getting plenty of ventilation because your lung parenchyma is still functional, but your perfusion or your blood flow is reduced. And so you're going to get a high VQ. And this can be referred to as a dead space. So just something to note is that 60 to 80% of pulmonary emboli are actually too small to be clinically detected, and so they're considered silent. However, once you get more than 60% of your pulmonary vasculature compromised, what's going to happen is the blood's not going to be be able to flow out of the lung and into the left atrium, and instead it's going to kind of start feeding back into the right heart, causing what's called cor pulmonale, which is right heart failure due to volume overload of the right heart. And this is combined with pulmonary hypertension due to the increased buildup of blood proximal to the occlusion. So the way that this is going to manifest can be seen in our signs and symptoms. So you're going to get things like, in terms of signs, you're going to get chest pain due to the involvement of adjacent pleura, which is, again, our sensory component of the lung, and cardiac ischemia. You're going to get tachypnea, syncope, depending on the size of the embolus. A sense of apprehension is actually found in, I think it was 53% of patients, so you literally feel like something bad's going to happen. You can get a cough, and hemoptysis, or coughing up blood, is a really, really common sign as well. Symptom. In contrast, the signs, which are the things that only the doctor can measure, include signs that point towards shock. So you get an increased rest rate, so tachypnea, you get hypotension, you get tachycardia, and a fever. And when listening to the chest, you'll hear sounds like rales, decreased breath sounds, and you'll hear wheezing. If it's gone so far that it's causing cor pulmonale, you'll also get signs of right heart failure. So you'll get an elevated JVP, a sternal heave from right ventricular hypertrophy, and you'll get an accentuated pulmonary component of the S2 heart sound, which is where you get the splitting of the heart sound due to volume overload. Now, in terms of diagnosis, the mainstay of diagnosis, the best gold standard diagnosis technique, is called the CT pulmonary angiogram, or the CTPA. So the CTPA is basically where they inject contrast into your pulmonary system, and they see where it stops distributing around, which would indicate that there's a blockage somewhere. However, it is a really invasive procedure, so although it is perfect for diagnosis, we usually do it after we've performed a D-dimer test. So what a D-dimer test is that it detects D-dimer, which is a breakdown product of fibrin. So just zooming over to our coagulation cascade here, you can see that fibrin is the final outcome of our coagulation cascade. So if you're breaking down fibrin, which is what the body is trying to do when there's a clot, you're going to also get D-dimer. And so an increase in D-dimer means that there's probably a clot going on somewhere. It's important to note that this test has a really high sensitivity, but a very low specificity, or a relatively low specificity. So that means it's really good at ruling things out if it's negative, but just because it's positive doesn't necessarily mean that there's a clot going on, or there's a pulmonary embolus or deep vein thrombosis. So it's not as good as ruling things in. And that's why you need to then, with a positive dimer, you would do a CT pulmonary angiogram. You can also use a technique called a ventilation perfusion scintigraphy, or a VQ scan, which measures the ratio of ventilation to perfusion. And you can, if you suspect a deep vein thrombosis, with or without the pulmonary embolism, you can ultrasound that leg to check for the flow through the vessels to see whether or not it's compromised. In terms of other investigations, you would do an arterial blood gas, and you would see hypoxia with hypocapnia and alkalosis, which would correspond to a respiratory alkalosis. Whether or not this is compensated with bicarbonate would be depending on how long it's been going on for. On a chest x-ray, it's really interesting because chest x-rays are something that we usually, call for? Prescribe? No, we usually ask for a chest x-ray whenever someone can't breathe properly, but in this case, chest x-rays can't really tell us anything because you can't really see clots in a chest x-ray. But what you might see is a prominent central pulmonary artery. You might see collapse of a lobe, aka atelectasis, and you might see fluid, which is collected due to the hypertension, aka pleural effusions. But seeing a normal chest x-ray is actually pretty normal, so it's not a super reliable source. Now, in terms of the ECG, I was trying to work this out last night because I've kind of been ignoring it. But the ECG, the most common thing that you're going to see is sinus tachycardia. So all of these other signs that are specific to a pulmonary embolus or classical patterns of a pulmonary embolus, they may or may not be present, but someone's going to be experiencing tachycardia regardless. So a couple of things that might be seen. Firstly, the thing that I find easiest to recognize is the right axis deviation due to the increased strain on the right heart. So you can see that by 1 and 3 reaching towards each other, which for me means right axis deviation. And you're also going to see a right bundle branch block. Or you might see a right bundle branch block, depending on how extreme the case is. And for me, I remember this by looking at V1 and V6. And if V1's making an M, and if V6 is making an N, it means it's saying the word marrow. Marrow. Yes. So, M and a V, a W or an N is right, as opposed to, as opposed to a William, which is WLM, which would be a left bundle branch block. Look it up on osmosis. It explains it much better than I do. Alright, other things you might see is a T-wave inversion in V1 to V4, and I only put a picture of V1 here, but that would be seen in V1, 2, 3, and 4. You might also get what's called an S1, Q3, T3, which is where you see a deep wave in lead 1. You'd see a Q wave in lead 3, and you'd see an inverted T wave in lead 3. But hopefully at second year level, we're not really expected to recognize that because I've never recognized it without prompting before. Okay, now in terms of what tests to run based on a person's risk factors, something that's really useful is what's called the Wells criteria. So basically, a patient comes in, you think they've got a PA or a pulmonary embolism. You can basically tally up how likely they are to have these things before you perform the invasive CT pulmonary angiogram on them. So criteria include things like signs and symptoms of a DVT, which I'll go through in a bit. If you think that the pulmonary embolus is very likely, if they have a high heart rate, if they've been immobilized for at least 3 days or had surgery in the previous 4 weeks, because remember this adds to venous stasis and hypercoagulability. If they've had a previous DVT, if they're coughing up blood, or if they've had, if they're palliative or have had cancer recently. So basically, if you add all of these up and there are more than 4 points, you would do a CT pulmonary angiogram. And if they had less than 4 points, you would simply do a D-dimer. But again, remember the D-dimer is good at ruling things out, but it's not good at not necessarily reliable for ruling things in. Before we go into treatment, I just wanted to mention this stuff. So signs of a DVT include unilateral pitting edema due to, so imagine we've got a clot in the leg here. We're going to get extravasation of fluid out of the blood vessels into the surrounding tissue, which will lead to pitting edema. You get erythema and warmth, calf tenderness, a palpable cord. And a palpable cord here refers to a thrombosed vein. So you can literally feel it, which I think is disgusting, but poor people. And what you might also see is if you measure the circumference of each leg, you'll see that the one that's erythematous and warm is likely to be swollen as well. There are also a bunch of other things that can cause emboli. Namely, you can get fat emboli, air emboli. I'm pretty sure that's what the bends are, but I can't confirm that. You can also get emboli from degraded coronary atherosclerosis. You can get tumor emboli, bone marrow from if you've like recently, say, fractured your hip and you've got bits of bone floating around those can go to your lung and cause you to and foreign bodies, which is unfortunate. Okay, so finally, treatment-wise, the mainstay of treatment is basically anticoagulation, and so you do you do initial anticoagulation using low molecular weight heparin, and heparin works pretty immediately. I'm not going to go through the entire coagulation cascade because it's here. But you can see that heparin works by inhibiting factor X and thrombin, which are pretty low down in the cascade, so they're going to prevent the formation of fibrin pretty quickly. You would also co-administer warfarin, but warfarin does work by inhibiting the vitamin K dependent coagulation factors, aka factor 2, 7, 9, and 10. And so because they're inhibiting the synthesis of these, warfarin works slower. So you give heparin and you also give warfarin, but the warfarin takes a few days to kind of start its anticoagulative effects. And then once you've got your D-dimer or CTPA conformation, you commence thrombolysis using tissue plasminogen activators, which, cause plasminogen to activate into plasmin, which breaks down the fibrin clot. And yeah, you can also measure someone's clotting ability or hypercoagulability using something called the International Normalized Ratio, or the INR, which basically measures the time taken for blood to clot. So if you have an increased INR, it means you have increased coagulability. Oh, you know what? I take it back. If you have a decreased INR, because it means your blood clots faster. Oh my gosh. Anyway, that is pulmonary embolism. I hope you enjoyed. I will see you